This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU webinar series. Today's topic is Cyberknife radiation therapy for the treatment of lung malignancies. At any time during the presentation, please feel free to answer any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Weintraub. He's a board-certified radiation oncologist who grew up in Bexley, Ohio. He did his undergraduate studies in history and neuroscience at the University of Miami, and then completed medical school at the Ohio State University College of Medicine. Then completed his radiation oncology residency at William Beaumont Hospital, Michigan, where he served as chief resident. Dr. Weintraub is eager to help make a difference in his patients' cancer care. He speaks fluent English and Russian, and in his free time, he enjoys traveling, photography, playing chess, staying fit, and spending time with family. He serves patients primarily in Suffolk, Patchogue, and oversees the Cyberknife and TrueBeam machines in Setauket. Dr. Weintraub, I'll pass it on to you to start the presentation.
Thanks for the introduction, Jonathan. My name is Alexander Weintraub. I'm a radiation oncologist. I work with the New York Cancer and Blood Specialists, and we have the privilege to treat patients with radiation. I oversee the Cyberknife machine in the Setauket facility, and that's a joint venture with Northwell Mather Hospital. So I was asked to speak on the topic. Specifically, we'll review the Cyberknife treatment for the management of lung cancer. So to give a little background on lung cancer, you see that screen? So overall, the incidence worldwide is about 35 people in the US per 100,000 people are diagnosed with lung cancer. And importantly, looking at the red bars, these are the mortality rates. So this is a very mortal diagnosis. Despite early screening, which is really the best way to catch these, just catching it earlier, lung cancer has a high mortality. By catching it earlier, we have an opportunity to intervene, and most of the treatments that we do with Cyberknife is for early stage lung malignancies. And looking at the distribution around the world, the mortality rates around the world, we can see quite high in the more developed countries, and that may simply be due to better diagnosis and identifying patients with lung cancer compared to poor developed countries. And similarly, the incidence is higher in more developed countries. Looking at the lung cancer screening, the lung cancer fact sheet, an estimated 154,000 patients died from lung cancer in 2018, and they comprise about 25% of all cancer deaths. So quite common and mortal. It's the leading cancer killer in both men and women ever since 1987. And it's because in the lung, a cancer can develop and grow and grow and grow and not cause any symptoms until it's metastasized or it's invaded a nearby object. And at that point, you've had a high cancer burden. And so it becomes much harder to eradicate and cure. So specifically, there were 238,000 new cases of lung cancer in the US in 2023, and 127,000 deaths from lung cancer. Lung cancer screening for the NCCN updated guidelines version 1.2.2024. We do risk assessment, and we have UPSCF guidelines and lung guidelines, but essentially it comes down to several exposure risks and family risks. So if you have a family history of lung cancer, family history specifically in first-degree relatives, we use that in calculating your risk, as well as a cancer history in general, because having other cancers in the family may indicate that perhaps your DNA is not as robust at preventing cancer development. And then we take into account personal cigarette smoking history, exposure to other potential radiation exposures in the environment, like radon, and occupational exposures like asbestos if you're a firefighter or if you work in a mechanical shop. And then we do these risk assessments and we figure out if you're in low risk category or high risk category. And sometimes if we're not sure, we may still have you do a lung screening. And so lung screening involves a CT scan of the chest where we do quick pictures. They're much more detailed than an X-ray. So X-rays aren't as good at detecting early stage lung cancer or early findings that may develop into lung cancer. And with that CT scan, we follow up the findings on the CT scan. So if we have small nodules, there are specific protocols and guidelines to help follow those up so that if they become suspicious, we could biopsy them, or we just follow them very closely with additional screening workup. Now back to the presentation, which is the actual management of lung malignancies with Cyberknife. Radiation has sort of formed the backbone of treatments for lung cancer. What is radiation therapy? Radiation therapy is a form of light energy. We use radiation every day for X-rays and CT studies. There's background radiation, background exposure from cosmic rays, background exposure from the ground, from other chemicals in our atmosphere. These are small amounts of radiation. The radiation therapy we use far exceed those doses on the threshold of 10 to 100,000 times more than those levels of radiation. And we target them using modern technology. Radiation therapy works to kill cancer cells because each dose of radiation, as we can see on the right side, results in smaller and smaller percentages of cancer cells that survive. And so initially when we treated cancer, we would give them multiple doses. It would be specifically about 35 doses to try to decrease the surviving fraction down to 0.0000. And so the only way to do that is to get that, to continue pounding those cancer cells with radiation dose. But at the same time, radiation dose also has some collateral damage to the normal tissues. So finding that optimal dose requires good technology, number one, and number two, a lot of patience. So we have a lot of data, a lot of clinical trials that helped us understand how to best treat patients with radiation. How does a radiation machine work? Essentially, we have electricity that goes through this machine called a gantry, and we send the electricity into an electron gun where we form high energy electrons. Electrons are propagated down the accelerating waveguide through a bending magnet down, it hits a target, and out comes high energy X-rays. X-rays are, the actual delivery of these X-rays is calculated with an advanced physics team, and this machine is calibrated through very intensive measures to ensure that the radiation is delivered very precisely. And there are constant checks annually, monthly, and daily to ensure that the delivery of the radiation treatments are accurate. How is radiation different in the current era? So in the current era, over the last few decades, radiation therapy has now developed incredible precision to the point that it's within 0 to 1 millimeters, also known as stereotactic treatments. Stereotactic treatments are very different than what we're seeing on the right side of the screen. On the right side of the screen is 3D conformal radiation therapy. What we used to do is have 3 beams like it's present, or 4 beams, and they would focus in on one area of the lung. So this one is in the middle of the chest. And as you can see, the medium dose, or the yellow and green amount of radiation, is sort of not that well distributed like on the left, which is a volumetric modulated arc therapy plan. And so the SBRT treatments, they sort of utilize all angles like VMAT, but it's stereotactic, so it's even smaller margins than VMAT planning. SBRT is a form of radiation treatment where we took patients' lung cancers that used to be treated for 35 treatments and compressed the radiation dose into only 5 treatments or fewer. Why did we do that? Well, what we found is from these studies, in specifically RTOG0236, this was a large study where patients had inoperable stage 1 or 2 lung cancer. They were treated with SBRT, and they found that using these focused SBRT treatments at 3 years, there was a very, very low failure rate, about 10% at 3 years. And that's very good for lung cancer. For patients who can't undergo surgery, you really don't have other options. So this was the long-term results recently published in 2018. And what they found was that these were the patients that they enrolled. They enrolled mostly early stage cancers, and they prescribed 54 gray and just 3 treatments. And they looked at survival, local recurrence, elsewhere failure. So survival still isn't great at 40%. Most of these patients who are inoperable have other medical comorbidities like heart failure, COPD. There are reasons why surgeons are hesitant to take them to the operating room. And overall, with radiation at 5 years, only 7% failed. So 90+% with this type of radiation treatment are cured with the definitive radiation. Now, mind you, there are still a percent of patients that have metastatic disease at the time of diagnosis or may develop metastatic disease from small cancer cells that we couldn't take care of. And so we're looking at other therapies like immunotherapy in addition to SBRT to become even more effective and help cure these lung cancer patients. So this is an example of stereotactic treatment. You have multiple beams coming in from multiple angles, sort of in the same plane, and that's delivered on a true beam or LINAC. And we'll get into the differences between that type of SBRT and the Cyberknife SBRT and why Cyberknife SBRT may be a better treatment modality. So how is Cyberknife a different kind of SBRT? Well, as you can see on this machine, the machine head is on a mobile arm that moves. And so this has significant advantages because other machines have to remain in very sturdy position. That's sort of how they've been developed because of the calibration and planning. This machine is sort of more advanced and now can actually move and still be exquisitely calibrated and precise. And the advantage of Cyberknife radiation therapy over these other plans is that, as you can see, this plan circles around in one plane. The Cyberknife actually has 4 pi degrees of motion. So by doing that, you distribute even more low dose radiation and further reduce the risk of any incidental side effects. Proton therapy is another interesting form of radiation therapy. Proton therapy is done at just very, very few centers around the country. Protons are a different molecule. And in the lung, Cyberknife still appears to be significantly better. You're done in only just a few treatments versus 6 to 7 weeks. The accuracy is much better, 1 to 5 millimeters versus 20 to 30 millimeters. Many more beams, whereas protons, they don't have that technology yet. They're working on it, but they don't have it yet. And most importantly, Cyberknife corrects for breathing and movement. It moves as you breathe. And so that overall shrinks the target area and reduces any incidental scar tissue that you may produce in the lung. So this is standard SBRT, again, just in one plane. With standard SBRT, you have to account for the motion management within the lung. So patients are breathing freely. And so we take 10 CT scans to accurately understand how the lung cancer moves in the lung. Because as you can see down below at 60%, the lung tumors moved up. And as you can see throughout the motion, it moves up and down. So you have to be able to account for where the tumor is at all points in time within the respiratory cycle. So to do that, we take 10 CT scans and then draw the tumor out on each phase of the respiratory cycle and then just composite it. And so that overall treatment volume is actually larger than what the Cyberknife is, because the Cyberknife uses a fiducial marker to track the tumor in real time. So this is particularly useful for tumors low down in the lung because they're closer to this big muscle called the diaphragm. And so as the patient's breathing, the diaphragm moves up and down. And so that could lead to a very significant volume from one of these generated plans, whereas with Cyberknife, it moves with it. So you have very, very targeted treatment while the patient's breathing. And what it does essentially is during the treatment, it constantly retakes pictures and readjusts to create the most accurate treatment delivery setup. It's another example of how conformal these radiation doses are. We have the 100% dose line in the yellow. And these are much smaller dose lines. So the 10 gray isodose, you can see 10 gray almost never causes any toxicities. So we reduce that incidental dose significantly with the stereotactic treatment planning software. How have stereotactic treatments changed the effectiveness of radiation therapy? With higher precision, we are able to deliver much higher doses per treatment and able to do it in less treatments, which is very convenient for the patient. The one caveat with treatment planning is we have to take meticulous caution with any OAR. OAR represents normal organs that are at risk of collateral radiation damage. So we have to account for these to ensure that there's no, or we minimize any potential radiation toxicity. This is an example of how we account for the tumor as it moves in time and space. There's a small bit of planning. And so with Cyberknife radiation therapy, the planning target volume is actually about 0 to 1 millimeters to account for the motion. And so the actual tracking of the tumor, though, up and down is 5 millimeters. And so it reduces the volume overall compared to standard SBRT. Here are some data where they did various SBRT regimens. These are basically any radiation regimen with 5 or fewer treatments. We have a formula to figure out what the total actual dose is felt by the cancer. And so we calculated this so we can see different ranges for SBRT treatments. And so what we found is that patients really need to be treated with a higher dose regimen, about 105, more than 105 grain. In fact, on the graph to the right, we can see even higher and higher BD leads to better and better local control. So with anything above 152, essentially no local recurrences. And these are from institutional data reports. So that helped us find the best dose to deliver. And we can see the 2-year local control is excellent, even better than what we saw before from RTOGO236 at 90%. This is 97, 98% now. And we have found various factors. We looked at max dose, min dose, various parameters in terms of the evaluation of the integrity of the radiation treatments. What in the lungs do we treat with Cyberknife? Well, we talked mostly about lung cancer, but we also treat metastases to the lung. Patients with metastatic cancer, with stage 4 cancer, sometimes have very, very, very few metastases, 5 or fewer to be specific. And if they're localized in the lung, it's challenging to take a patient to the surgical suite to remove a large segment of the lung when you can do radiation, very, very targeted. It spares more lung. And it's also very effective at eradicating those cancer cells. Also, a third scenario where we may use a Cyberknife is for particularly challenging scenarios. And for all these scenarios, usually inoperable patients or patients who refuse surgery, or in patients who doing the surgery seems too high risk, or the patient prefers not doing the surgery, when radiation is also a very, very good option. Medically inoperable tends to mean the surgeon is just very hesitant about taking a patient to surgery. And we have different metrics that we measure, mainly lung function, heart function, and other comorbidities that we look at to assess whether or not a patient will be fit to go through surgery. If they're not, then usually radiation is the default. Things that we don't treat. Number one, are very ultracentral tumors. These are tumors that are just abutting the heart or esophagus or aorta. Sometimes we can get away with it with careful planning. But as you can see from the first 5 rows, the grade 3+ and grade 5 toxicities can be quite devastating and high. And these are all for the 5 fraction or fewer treatments. There are a few that are 10 and 12. In the 70 and 10, though, we can see the grade 3 and 5 toxicities are actually much lower. So we prefer more treatments spaced out over time for tumors that are very, very, very close to critical organs. And so we have to compromise because our dose isn't going to be as high, but still it's safer if we deliver more doses. So moving down, this is sort of an example of an ultracentral tumor. It's very, very close to the right bronchial tree as outlined by the green arrow. And so this area within the dotted lines sort of demarcates the central zone. Ultracentral is within 1 centimeter, so it's even less. So this again outlines the central zone. Ultracentral is even tighter. And this is an example of an ultracentrally planned tumor that we did. And this was planned with 12 fractions because our priority is to make sure that this radiation is delivered safely without causing any death or toxicity. Also, we don't treat patients who have tumors that are way too big to be encompassed with the SBRT planning. And patients with lymph nodes in general, we don't treat. Why? Because, well, lymph nodes are usually ultracentral. This lymph node here in the yellow is right next to that right bronchial tree that we saw an example of here. So similar location. So in terms of non-small cell lung cancer management, which patients do we treat? In general, these are earlier stage patients that are N0, and you can see with the NCCN guidelines for negative mediastinal nodes, medically inoperable, N0. Definitive RT is preferable with SABR or stereotactic ablative body radiation therapy. Also, it's another word for SBRT. And then in high-risk patients, you can consider immunotherapy or chemotherapy afterwards. But really, radiation is the definitive if you can't undergo surgery. But if you're operable, surgical exploration is preferred approach because that's been the standard for a very long time. We're still waiting on data to evaluate which one is best for in the upfront setting, but for now it's surgery. So early stage lung cancer, here are some plans from patients that we've treated. As you can see, very, very conformal treatment and overall minimizes the incidental radiation toxicity risk. Oligometastases is another plan that we're able to do. And so this one, we had enough distance from this critical central organ, and so we're able to deliver that safely. There are also tricky situations. For example, when the lesion is too close to a pacemaker on the left, you can see a metal shining object just above that orange area that's measured about 1.5 centimeters. And on the on the right, we see the PET scan in the same location. And so this is a patient where Cyberknife was important because if the patient put their hands up, it moved the pacemaker above. The pacemaker is sensitive to radiation. It can only tolerate a small fraction of radiation. So that was important to avoid. Here's another example where we had a pacemaker issue. Typically for stage 3 lung cancer, we don't use Cyberknife radiation therapy. But this patient actually had lymph nodes in addition to the lesion. So they were a stage 3 cancer. And so by moving their arms up, the pacemaker moved up. And so we're able to ablate that lung lesion. And to be honest, with the Cyberknife radiation therapy, it's very impressive. By delivering higher doses, it seems like the response may even be better. And so then the patient's arm were placed downwards and we finished treatment with the lymph node for 30 treatments with the concurrent chemotherapy. And we accounted for the prior radiation plan now outlined in the orange and the pink. And so as you can see on the right is sort of the before scan of the stage 3 findings. So first you have the lung tumor, and then above in the neck and the supraclavicular fossa was this lymph node pointed out in yellow. And on the left, you can see that the where the fiducial marker remains at the top left for the Cyberknife treatment. And at the bottom left, you can see how the supraclavicular node is has totally gone. So this was a really great response, and the patient went on to immunotherapy afterwards. So to summarize, the tracking of the fiducial is important in certain setups. So in certain tricky situations, it can be very resourceful to have a Cyberknife machine. Also, when the tumor is very close to that muscle that we talked about, the diaphragm muscle, because there's significant motion up and down, this would be the preferred treatment approach because you have a fiducial tracking it instead of having to cover this whole area. As the diaphragm moves up and down, you'd be covering much more lung tissue. And so you want to reduce the risk of any side effects. Pneumonitis is a very, very important side effect that sometimes can happen in patients, and it can cause a significant sunburn or sun reaction within the lung and inflammation, an inflammatory state where your immune cells come in and the lung just isn't functioning as well. This is difficult to manage at times. We require long courses of steroids for the patient, and we follow up, and it can be tricky because the area that's inflamed may look like it's a tumor, but often it's not, and it just remains inflamed. And it sometimes can be fatal. It sometimes can cause patients to be on oxygen for more oxygen or oxygen for the rest of their life. So we take that very seriously in the planning. So potential complications from SBRT to the lung. Whenever we treat with radiation doses in the lung, there are scatter doses that go into the lung that may cause this side effect that we talked about, pneumonitis, that's lung inflammation. Some of the radiation damage could injure the heart, leading to vascular changes, atherosclerosis, and arrhythmia. Sometimes if we're too close to the airway, that central ultracentral zone, we're very worried about bleeding. Those are those grade 5 toxicities if the patient dies from it. So we're very cautious of any airway bleeding, potential complications. Very rare is spinal cord injury. We're so far away from the spinal cord usually, and our technology is so improved that it's very, very rare, but it's on that same level. As you can see here, these isodoses in the top left are bending around that spinal canal. So these are very low doses. The spinal cord can tolerate much higher. But that is a concern. And brachial plexopathy. So the brachial plexus for higher up tumors closer to the brachial plexus, like this one in green. So the brachial plexus runs through there. You can see it in yellow. It can result in a brachial plexopathy, and brachial plexopathy may mean numbness, tingling in the hand, or pain. So we make sure patients are well counseled. And there's a very, very rare theoretical risk of second cancer. Happens because when we damage the DNA of cancer cells, we incidentally damage normal cells. Usually, if there is a second cancer, it happens 10 to 15 years after the radiation dose exposure. And we weigh the risks and benefits extensively. Given the very, very aggressive nature of lung cancer and the very, very theoretical risk of second cancer, the benefits usually far outweigh the risks when we make this recommendation. This is an example of pneumonitis in the bottom left, where the patient was treated in the top right. And then it can occur anywhere from 6 months to 18 months after the radiation course. And so management may include steroids, antibiotics, pulmonology co-management, and at times patients can become oxygen dependent. Okay, at this time, open any questions.
Thank you so much for the presentation. Yes, if anybody has any questions, you can enter them in the Q&A feature at the bottom of the screen. All your questions will remain anonymous. We'll give it a few moments here to see if anybody has any questions, okay? I don't see any questions coming up. So I just wanted to thank everybody for joining us, and thank you, Dr. Vaynerchuk, for your presentation. If you have any additional questions, you can please email them off to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you can please complete the survey, your feedback is extremely important to us and helps us plan our future programs. I just wanted to thank you all again today. And if you're interested in viewing past HealthyU webinars, you can view them at www.matherhospital.org/HealthyU. Thank you all so much. I'll give you a few seconds to take down the cell phone number here. But again, thank you everybody for joining us.